Assalamu alaikum. Good morning, everybody. It's a pleasure to be here again. Thank you for the organizing committee for inviting me for the third year. It's an honor to be amongst you guys, and it's an honor to see so many familiar faces and definitely some new faces. So we're going to start off and kick off the day by our interesting track of critical care. Our first speaker is Dr. Aref Malabarey. He's an assistant professor for emergency medicine and critical care medicine at King Saud University, King Khalid University Hospital in Riyadh, Saudi Arabia. He's also an expert in echocardiography, and I believe he's probably, if not the first, emerge critical care echocardiographer. So it's an honor to have him over here. He's going to talk about monitoring in the emergency department for critically ill patients. I have all confidence it's going to be an entertaining talk. So without further ado, Aref, you have the podium.
All right. Assalamu alaikum. Good morning, everyone. I just want to echo what Aziz said. Thanks for the introduction. I want to thank my ESEM friends again for inviting us for the third year in a row. So thanks if there's anyone in the room. Thank you so much. Okay, so I'm gonna go ahead and start my my talk on critically ill, monitoring the critically ill in the emergency department. It's quite an important topic because probably we don't do very good at it, and I'm talking about myself as well when we're talking in the emergency department. So I'm going to start by a quick honesty test this morning. So how many of you, regardless of how sick the patient is, he can be septic, COPD, bronchial asthma, cardiac arrest, procedural sedation, how many of you monitor your patients like this? Good. So we have a few honest people in the room. That's good. So this is what we do. Really, when it comes down to monitoring, we can have the sickest patient, and I would say 90% of the time, this is what we're looking at. We have a heart rate, which is important. Saturation, definitely very important. Respiratory rate, I'm not going to give you much credit for that because it comes with the saturation probe as well. Blood pressure is okay, but this guy is okay. His blood pressure is fine, so probably this is all he needs. But what if we have someone that looks like this? Saturation, maybe the probe isn't, it's not a good wave anyways, I'm going to ignore the saturation. But what about the blood pressure? Can anyone tell me what's wrong with this patient? The patient is pretty hypotensive. Yes, I know I am going to rush him to my critical care area, but can anyone tell me what the problem is? He's hypotensive. Does he need fluids? Does he have a problem with his heart? There is no way you can tell, but we rely a lot on this, and we make critical decisions based on this, when I can tell you this might actually be a pretty nice mistake that should be avoided. So I'm going to move on. How many monitor their patients like this, the critically ill ones? The only difference here is we have this little thing right here. Routinely, how many of us use it? Okay, very good. So it's for reasons beyond me, I don't know, despite the very good evidence. I'm going to go over it very quickly. We don't use it routinely. Still not clear. All right, so how many of us in the emergency have something like this? And what this is, basically, it does have a heart rate, blood pressure, saturation, end-tidal CO2, arrest rate. It gives you the inhaled gases, but it has this little thing. It has cardiac output and cardiac index monitors for critically ill. Does anyone have this in their emergency? Okay, probably not anytime soon, but these are very non-invasive devices, and I'll just go over them very quickly. If we do understand the basic physiology, maybe we will subconsciously start looking for things that give these kinds of answers. Now, the ultimate questions whenever we're monitoring patients is, are we getting oxygen to the tissues? Now, this is going to be divided into two pathways. Pathway number one is going to be, how much oxygen do we have? So we need to have oxygen first. The next step is going to be, how are we going to deliver the oxygen? Okay, so these are the two components. So the first thing we're going to talk about, or the way we're going to monitor them, are going to be twofold, or two different pathways. We have the respiratory monitoring and the hemodynamic monitoring. The respiratory monitoring is divided into two physiologically completely distinct processes, physiological processes. One of them is oxygenation and the other one is ventilation. Okay? Now, this is probably one of the most important equations for me, at least in clinical practice. I teach it and I preach it every day when I'm working. This is the oxygen content equation. Okay? So it shows you that the saturation has a pretty large value. So it's saturation multiplied by the hemoglobin multiplied by the constant, which is a large constant. It's over 1. Okay, so whatever value you have for the saturation, it's going to be above that. And then we have the PaO2, which is again multiplied by a very low factor, which is 0.003. And this is why we don't like to give so much weight for the PaO2 unless in very specific situations we're trying to measure specific things in ARDS or AA gradients, or, you know, they have their own little indication. But in general, if you want to look at oxygenation, probably the thing you should go by is saturation. I'm not going to talk too much about saturation because we all do it. Now, even if you don't do it, EMS is going to do it. Even if EMS don't do it, the nurses are going to do it. Even if the nurses don't do it, the patient's going to, you know, it's like, it's going to happen regardless. So how do you fix a hypoxic patient? And this is important for the next step. What's the first thing you do if you have someone who's hypoxic? So you put them on oxygen. Good. So what's the next thing you do? If he's still hypoxic despite the oxygen, in other words, he is eliciting some kind of a shunt physiology. So what do we do? Anyone? Good. No one said anything. That's fine. So we add a bit of pressure. So the reason I put this up is you can see that breathing has nothing to do with the oxygenation process. Okay. So we have FiO2, which is just slapping a mask on or just increasing the FiO2 if the patient's ventilated. Just go up on the dial. Or the next step, if you're still hypoxic, you increase the pressure. But there's no respiratory rate or tidal volume in this process. Now the second thing is ventilation. Now again, this is divided into two, respiratory rate and tidal volume. The minute ventilation is respiratory rate multiplied by the tidal volume. Now in other words, ventilation is breathing. Now what is the parameter you look at when you're assessing ventilation? That's going to be your CO2. Okay, so this is the parameter you're going to look at. So if anyone here is interested in assessing whether or not your patient is breathing or hypoventilating, or, you know, there are so many other indications, CO2 is the way to go. So for me, this is one of the must-haves in the emergency department. Must-haves. You need to know whether or not your patient is breathing. Studies have actually shown that physicians are bad in detecting hypoventilation and apnea, actually, especially talking about procedural sedation. You're giving the patient medications. It's okay, probably you just went a bit over and your patient starts to, you know, become a bit apneic or hypoventilating, and you just don't detect it unless the patient starts to become hypoxic, which is probably a bit on the late side. Anyway, it's a big topic, it's a big debate, but I like to know when they stop breathing now. Like, they stop breathing now, I would like to know now that that they stop breathing. So a CO2 capnography is the way to go. There are so many other indications. The very, very strong evidence-based indications for monitoring is for procedural sedation, confirming the ET2 placement, and having a beat-to-beat or a continuous monitor if there's any dislodgement or any kinking or obstruction of the tube. And the other one is for assessing the how good your CPR is, and for mortality prediction as well. And this is all in the ACLS guidelines. Now, and this is what you're expecting to see. And again, end-tidal CO2 is a chapter on its own. Dr. Al-Malek spoke about it, I think, last year or 2 years ago. A full lecture on end-tidal CO2 different patterns, but it's a very, very valuable tool, and it's one of the must-haves for your critically ill patients in emergency. Now, how do you measure it? We do have very portable devices, just like the oxygen sat probe. You just slap it on, and you do get a reading. Others, like the one on top, like this one, the MMA capnometer. It's made for the mainstream or the inline tubings. You just put it after the tube, and it will give you a reading. Probably a bit advanced, but for us in the departments, 90% of the monitors, if you just look at the side, this is actually me. I was curious in the department. We do have a little lever you just pull down, and you do have an area where you can connect your CO2 line. And even for non-intubated patients, you can just attach a little line. Matter of fact, I'm an ex-anesthesia resident when I did my residency. For the patients who were not intubated, we used to get a line. We just put it underneath. We didn't have these little connectors. We used to put it under the face mask. Even if it doesn't give you a correct and accurate value, it just shows you a pattern that the patient's breathing, which was good enough at that point. So something is in terms of value, it is very, very valuable. Now, the next part is where really the meat is, which is the hemodynamic monitoring. Now, again, it's the question. Now, are we getting oxygen to the tissues? And this is going to be, are we delivering oxygen to the tissues? Now, this is where the delivery part comes in play, and we're talking mainly about the cardiac output here. Now, achieving a balance between organ oxygen delivery and oxygen consumption is the main thing we're looking at. We need to get to that balance. Okay, and this is what it shows. So we do have oxygen delivery, and we need to make sure. So if we give oxygen delivery beyond the oxygen consumption, probably you're not doing your patient a service. So you need to be somewhere around this line, and this depends on so many factors. We'll go over it in a second. So let's go back to this patient. Now, blood pressure is a product of so many different things, okay? So it's an end result of so many different things, and it's a very valuable, but it's a very crude evaluation of your patient status. Blood pressure can be due to a very low systemic vascular resistance because of vasoplegia. It can be because of a low cardiac output, and the cardiac output can be because of a low stroke volume. Heart rate is a bit obvious, but the stroke volume can be due to volume, can be due to poor contractility, can be a very high afterload, so many different things. So it's impossible to look at this number and say, boom, I have the answer, I know what's going on. What is our immediate response? We immediately give them fluids, which is okay, but this is one of the things that need to be absolutely monitored. So this is like the absolute basics, and trust me, when I'm in trouble in the emergency or in the ICU, I sit down and I put this down in notes and I say, is it this? No. Is it this? I assess it. Is it this? I assess it. Is it this? I assess it. So I take each one of them and I start ticking them off until I find the answer, and it has to be somewhere along these variables. So the initial assumption for us is always going to be give the patient fluids, which is not wrong, but you need to be very, very careful when you're doing it, and it might have catastrophic issues afterwards unless you monitor what you're doing. So how many of us have seen a liter bolus? Come on, everyone's seen. What about 2 liters? What about 4 liters? 4 liters bolus. It's pretty common, guys. Has anyone seen 7? I've seen 7. Like 7 in like less than 2 hours because the patient remained hypotensive. Like these are the things that we are guilty of as emergency physicians. We do this. This was recently during my training. So we do give fluids. Now the question is, when do you stop giving fluids? And this is where it's a bit tricky. And this is where I think one of the things we need to one of the things that really need to be monitored. So if we give fluids, preload, you need to make sure that every single drop of fluid you give needs to contribute to the cardiac output, otherwise it's useless fluids. In other words, it might actually be harmful fluid. So if you give fluids and you're reaching here, to this area, it's not contributing at all to the cardiac output, but preload, it's going all the way. It's more edema, ARDS later on, positive fluid balance. The patient might not die now, but we care for the patient, period. We don't care for the patient now. We care for him even a few weeks down the line. They might develop ARDS, and a positive fluid balance on its own is an independent predictor of mortality. So giving a lot of fluids, probably not very safe. Now, this is Paul Marek, a very famous intensivist, very well published, did a lot of work on CVP. So he says, give the patient all the fluids he needs, but not a single drop more. Okay? It's a bit tricky. It's a bit tricky. It's very, very difficult to tell. But you need to be very cautious when you're doing these things. So how much of the fluid you're giving is contributing to your cardiac output? So the thing we're talking about is actually fluid responsiveness. Now, on purpose, I just mixed it up. It's nothing to read. There's a lot of work on the CVP, and each one of them tells you that CVP on its own. Right? They don't actually say on its own, but CVP is bad. Okay? You can just look at the CVP is a poor marker of fluid status and a poor marker of fluid responsiveness. Does anyone agree with the statement? CVP is bad? Sure, CVP is bad. The only thing that wasn't mentioned except for one of the papers is that CVP on its own is bad, I agree, but if you combine it with the cardiac output, you're looking at both ends of the spectrum, then it might be pretty useful. But again, CVP has its own issues. The alternative that seemed to be a bit better is using ultrasound. So I use, and I encourage everyone to use, ultrasound as a monitoring modality. It's not a one-time thing. I have an ultrasound, it's at the patient's bedside. If he's the sickest patient in my department, I tell everyone, do not move that ultrasound machine, because I'm coming back after 5 minutes, I'm coming back after 10 minutes, I'm coming back after the fluid bolus. So it's pretty crucial for me to use that ultrasound machine. So this is just a small video. This is a collapsing IVC or a small IVC. You give them a lot of fluids, or you give them a liter of fluids, and then it will look something like this. So you can see the IVC. So initially the IVC was flat. This is the IVC, and with breathing, it's not moving, it's not collapsing. And there are different values. Some say 13%, 18%, 50%, but it's basically moving or like responding or not responding. Well, with the respiratory variation, you can tell. Now, the other thing actually, we just mentioned this. So what's missing? We're only looking at the right side of the circulation. We're only looking either the CVP or the IVC. We're only looking at one side. We're only looking at this axis. We're completely ignoring this axis. So we need to have some kind of a way to measure this axis. And this is where, and there's a lot of studies, emergency and critical care for non-invasive monitoring, because historically it's always been monitoring. Now the other thing is echo. Now if you have a flat IVC, and this is where it's good to combine the right side of the heart with the left side of the heart, okay? So, or the cardiac, so the preload and the contractility. So if you have a flat IVC with a heart that looks like this, what you can see here, it's a pretty hyperdynamic, empty heart. The ventricles are collapsing. So maybe this is a guy who is going to need the fluids. You give the fluids, and then slowly you're going to see that ventricle expand. Now, on the other hand, if you have a ventricle that looks like this is a parasternal long axis view. So this is the left atrium, mitral valve, left ventricle. You can see the anterior and posterior walls barely contracting. This is an apical four-chamber. Again, you can see this is the left ventricle. You can see it barely contracting. So this guy, fluids will probably not help this guy. Okay, so this is a guy, avoiding fluids would be a good thing. He might need more inotropes, or, we need to find the cause. Now, historically, I don't want to say historically because just recently in training, we used Swanganz catheters quite generously actually, but it's not something for the emergency at all. Although this does give you PA pressures, cardiac output or cardiac index, it gives you a CVP, it gives you so many different monitorings. There's been a lot of issues with using the pulmonary artery catheters, a lot of problems, complications mainly due to insertion. and people not knowing how to interpret or not interpreting the numbers. So there were some issues. Now the newer devices are the devices that are completely non-invasive. I would say I've used the Vigileo. This requires an arterial line, so maybe a bit invasive. This one is the CardioQ, which is an esophageal Doppler. You need to be intubated. You just put the probe down, and it actually gives you the numbers. It gives you the cardiac output, the cardiac index, and it gives you all the measurements that are pretty critical. So what you do with these numbers is you give the fluids, and then you look at the other side. Did it contribute to your cardiac output? If yes, continue to give fluids and keep looking at the cardiac output. So it really has to be the balance of both. Okay, and it's just the next thing for us in the emergency to start probably one day have these things as routine. Okay, and I'm actually working on a paper right now. It's called Cardiac Output in the Emergency Department, the Missing Vital Sign. So we'll hopefully next year, if I meet you in the same place, I'll be able to talk about it. So my take home, BP alone tells you your patient is sick, maybe, okay? And that's as far as it goes for blood pressure. And that's my take on blood pressure. It's very, very important. But looking at the blood pressure and start treatment based on blood pressure is a bit probably not very on the safe side. The CVP, the IVC alone is not much of use unless you combine it with the cardiac output. So not only the right side and the left side. Ultrasound echo, easy, reliable tool for monitoring. It's not only for getting that and leaving, it's for monitoring. Cardiac output alone, again, is not of much use unless you're combining it with other things. Now you need to know that you need to know that your cardiac output is actually doing something by looking at lactates and central venous saturations and other things. And the combination of different variables is the key thing. Looking at one thing alone is not of use. You really need to put multiple variables together to come up with answers. All right, that concludes my talk. Thank you very much. Any questions? No questions? No questions?
Well, thank you, Aref. Very interesting. So we are quite squeezed in time. We have the option of taking a question now if you want. And if you have more questions, we'll leave it to the end of the session. So any questions? We're going to take one single question for now. All right. Okay, so we're going to move.